My name is Mike Fishbein. I'd like to welcome the audience. We're going to be talking this evening about prostate cancer controversies. It's a subject that is close to my own personal life, having had cancer, prostate cancer, in my mid-50s. And it's, I think, a subject that really is not spoken about very much. And it's a subject that I think is of interest, obviously, to the community. Basically, 1 in 6 men will develop prostate cancer at some point during their life, and between 3 and 4 men will succumb to prostate cancer. So it's a subject that is of interest to us, and I think it's a subject that really has been under-discussed. I have a very distinguished panel here that will participate in this discussion. I have Dr. Keith Bleiler, who is a urologist at Falmouth Hospital, Dan Canaday, who is a radiation therapist, and Dr. Peter Hopewood, who is a general surgeon, as well as Commission on Cancer State Chair for the American College of Surgery. So I think I'd like to just start the discussion by asking Keith, really, where is the prostate gland, what does it do, and why does it cause such havoc?
Right. Well, the prostate gland is the sort of sits at the intersection, connects the bladder to the urethra, and it's the main source of, or one of the main source of fluids for making babies. Mm-hmm. So beyond it's one of the reproductive glands in the male, and beyond the reproductive years and making babies, the prostate gland really just makes seminal fluid. Mm-hmm. It really has not much use other than making babies.
Okay.
Well, continue.
Okay. And then, Peter, I'd like to ask you, what is it that happens in a prostate gland when it becomes cancerous? What happens to the cells, and why does it eventually become something where it could threaten a person's life?
Well, when the cells start to mutate and they have extra growth patterns, so rather than just staying where they normally are, they'll start to spread, and then they can spread to other parts of your body, and they can spread to lymph nodes or to bones. So it would be sometimes the prostate will start to get enlarged, and there may be some symptoms related to trouble urinating. And then as you go on with the prostate cancer, you may start having some more discomfort in urination and may start noticing some aches and pains. So some people show up with prostate cancer with a pain in a bone that won't go away, and they'll come to a doctor and they'll get an x-ray and find that there's something in the bone that traveled there from another source, and then we start to search for that source. So the cells they have a growth pattern which is well beyond normal, and they start to grow and spread out of control.
I think it's fair to say then, based upon what you've said, that there's a stage where the cancer is spreading within the prostate gland, generally where it's asymptomatic and the patient is unaware of it. At some future point, in some patients, it may spread to the bone, at which point it's beyond the prostate gland. At that point, it's not really amenable to local surgery with either radiation therapy or with surgery. So one way of thinking of it is that it's desirable, obviously, to try to find the prostate cancer when it is still confined to the gland. I think in the really up until recently, at least through the 90s, the hope was that the PSA test, along with digital rectal examination, would detect these asymptomatic cancers and have an impact on survival. To some extent, that has been realized, but I don't think to the extent that we had hoped. And there's been a rethinking of the PSA testing and digital rectal exam. And I guess I'd like to ask Dan first, really, what is the PSA test?
Well, the PSA stands for prostate-specific antigen, and an antigen is a protein that is secreted from a gland in the body. Prostate-specific means it is only produced in the prostate. So it's a very helpful test because the prostate is the only thing in the body that makes it. So all men who will have a small amount of PSA circulating in their bloodstream, where it's very effective to us is that if someone develops a cancer, the PSA value in the bloodstream will go up. The conundrum is that there are other things that can make the PSA go up, including having an enlarged prostate, having an infection in the prostate. But for us, it is a very, very effective and very sensitive way to pick up any changes in the prostate, and that can often indicate prostate cancer.
Okay.
It's a very simple test, it's a blood test, it's taken in the lab, we have the results within a few hours, and it's a value, and we can monitor this over time to see if there are changes in the prostate as well.
Okay.
Let me add, Mike, that back in the late 80s when this prostate-specific antigen was was first found out, actually it was an OB/GYN doctor doing bench research that detected this protein. What we found is that men who had real severe cases of prostate cancer had very, very high PSA levels. And men with very, very low PSA levels had no risk of prostate cancer, almost no risk. And the controversy exists because 99% of all guys have a PSA value in some range between 2 and 10, and that's where some of the controversy exists with screening. I wanted to add too, you brought up a great point that the vast majority of men don't have any symptoms at all. So I don't want guys to think that because they get up a few times to urinate or their stream's a little weak or having some urinary symptoms that they have prostate cancer. That's mostly not the case. It's just like you said, asymptomatic most of the time.
But once again, if someone has some symptoms of urination and it's going on for a few weeks, then you really should check that out with your doctor, find out what's going on. I mean, you could have a simple urinary tract infection, you could have enlarged prostate doing this, and then you would probably see your doctor, he'd probably examine you, might do a rectal exam, feel if your prostate's big or not, may order a PSA at that time. And that would qualify as sort of a screening, and the minimum of a screening would be probably a PSA and the rectal exam. Do you think, Keith?
I think so.
Yeah.
So maybe I would ask you all, how do you feel about PSA testing as a screening test for prostate cancer rather? I had the test done. I don't think my prostate cancer would have been detected had I not had it done, as is true really with my brother, my uncle, and my father. So because of my personal experience and because of my family history, I would say I'm an advocate of the test, but I do know that it detects prostate cancer that may not be important during a person's life, so-called overdiagnosis. So in the whole spectrum then of screening for prostate cancer, where do you fall? How do you counsel your patients? Do you tell them that they should have the test, shouldn't have the test? What do you do? I guess I'll ask you first, Keith.
Sure. Well, you had clearly a case where something was handed down genetically in the family that put you at risk for it, and you're an advocate for the test. And I think it's easy to be an advocate for the test if you use the results of the test responsibly. I'm a big fan of the test. It's a relatively inexpensive blood test. It can be followed over time. And I think that what you do with the test, or what the test results are, is the biggest factor. I think it's a great test to have as a baseline because the statistics are that 1 in 6 men may develop problems from prostate cancer. Dr. Hopewood's provided some statistics from the Massachusetts Department of Public Health, which shows that the death rate from prostate cancer is almost as high as the death rate from breast cancer in females.
I think we have that slide. If they want to show that slide while we're talking for a little while, and we can put that on the screen right now. Okay? Keep talking, Keith.
So I think as a baseline exam, and that's something that can be done when a guy is in his 40s or 50s, late 40s or early 50s as a baseline test, and then followed from that point in time, I think that's the greatest value in its use, because that's all we have right now. Eventually there will be a better test to screen men for prostate cancer, but right now all we have is this blood test, and there's a lot of play in its value, and there's a lot of prostate cancers that probably don't need any treatment, but we'd like to catch those guys who are going to develop problems from prostate cancer, and we really don't have any other way at the present time.
Well, Keith, can you talk about what you do with the PSA and what the next step is, because that's really your job?
Sure. Most of the time when patients come to see me, they have had a PSA test from their primary care doctor, and it's somewhere in a value between 2 and 10. And I talk to them, try to find out, do they have a strong family history of prostate cancer? Are there any other factors that might cause this test to be erroneously elevated? Had they had been treated for a urinary tract infection? on an exam, do they have a very enlarged prostate? Does their prostate feel suspicious? Does it feel hard or nodular? So we'd use the results of the test to make a decision about whether or not to move on to do a biopsy of the prostate to see if any prostate cancer exists. So that's the first level of decision making that you have to come to grips with. Once you've made a decision to maybe move on to do a prostate biopsy, you have to say, okay, well, if I'm going to use these results of the biopsy to either A, make a decision to treat this guy and cure him of prostate cancer, or B, we're going to just watch things, knowing that he might have prostate cancer, but it certainly isn't going to catch up to him and cause him any immediate threat to his health. So I think the biopsy and the PSA test and the rectal exam all break people down into a low risk, intermediate risk, or a high risk category. And then you can make a decision about what's the best form of treatment for them at that point in time.
So Keith, let me ask you this: how do you do the biopsy? Do you just feel the prostate gland and then put a needle in it, or what do you do?
You know, the rectal exam has been the butt end of a lot of cartoons and jokes and Seinfeld episodes. So yeah, unfortunately, the best way to examine the prostate gland is by doing a digital rectal exam. The examiner puts on a glove, he puts some lubrication on a glove, and checks the inside of your bottom. The biopsy of the prostate is done very similarly. It's an ultrasound technique. It's about the size of a finger, and through that little ultrasound probe that goes inside the rectum, just about 1.5 inches, there's a little guide where you can get a needle and you can take little core-directed biopsies, and the ultrasound's pretty good at localizing the parts of the prostate gland that are going to be at highest risk for prostate cancer.
So let's say it comes back and the pathologist looks at it under the microscope and he says, prostate cancer. Is there more information than just the diagnosis? Do you get some sense of the severity of the prostate cancer, the extent of it?
Absolutely.
What data do
you get a lot of information from that, and that really helps guide your decision-making process on whether somebody needs treatment. It tells you how many biopsies they had done, how many biopsies were positive for cancer. It tells you what the aggressiveness or the grade of prostate cancer, something called the Gleason score, and it's really just a number assigned to the aggressiveness of the prostate cancer. So that's the information that you get right off the bat. It's very helpful. We sit down and then have a discussion about those factors, and those factors have withstood the test of time, even with the controversy with the PSA testing. The PSA test, what the prostate feels like, and what the Gleason score are still predictive today as to the longevity of the patient and any problems they may have down the road.
So now you mentioned earlier, you alluded to the fact that some patients who actually have the diagnosis of prostate cancer are not immediately treated. And they fall into this category that we call watchful waiting or intensive surveillance or whatever,
Right.
but they're not treated. What do you do with those patients? How do you follow them?
Well, the concern is that doing this PSA testing, we're going to utilize a lot of financial resources in the healthcare system, and we're going to unnecessarily subject men to a treatment that is potentially full of significant sexual side effects and possible urinary side effects, which I believe are a little bit overstated in this day and age, but we can get into that in a little bit. Once the biopsy really breaks men down into what I call a low risk, intermediate risk, or a high risk category, and a guy with a very low risk prostate cancer, maybe just a couple of the biopsies are positive for prostate cancer, they're not an aggressive type of prostate cancer, and the actual volume on that specific core of tissue is very low, I think that the guy has a pretty low risk of having any immediate threat to his health as a result of progression from prostate cancer. I mean, we're talking 10, 15 years of a slow-growing cancer that may never cause any problems down the road. So I think you have to take into account the patient's health, take into account what's the anxiety level of the patient, Do they have a strong family history? Did their family members go on to develop more aggressive forms of prostate cancer? And whether or not this patient is going to develop problems down the road. It's a judgment call, really, what it boils down to. It's common sense, and it's a judgment call as to whether or not the patient's going to develop a problem, or whether you perceive the patient's going to develop a problem. I think there's a lot of data to support the active surveillance protocol, and I think used in the right set of circumstances, you're not going to burn any bridges in potentially providing treatment down the road for a patient, and you're not going to miss a cancer that could have been treated a long time ago.
So you basically follow their PSA testing, you repeat their biopsies as necessary. If you see a trend towards elevated PSA test, more concerning biopsy result, that would be an indication then that you would intervene. So let's say that happens. I'm in the active surveillance and my PSA keeps rising, my Gleason score gets higher, then I'm left with the decision now I have to have treatment. I'm going to ask Dan, come to you, Dan, I want your advice. Should I have surgery? Should I have radiation therapy? How do I decide?
Well, it really goes back to Keith's point that our job as oncologists is once you have a diagnosis of cancer, we try to put you into a box. You're either a low risk, an intermediate risk, or a high risk, and we do something called staging the tumor, which can also include things like doing x-rays to try to assess just, is the cancer confined to the prostate, has it spread beyond the prostate? And his point is an excellent one that, prostate cancer is unique in that in the earliest form of prostate cancer, these can literally be so slow growing that you can die of old age before the cancer becomes a problem. But we all know that there are people, as you say, who are just being watched, and they might jump into the next group. If they become more aggressive, then there are a number of very good ways to deal with it, but they all kind of are at different levels of aggressiveness. Keith is a surgeon, so he's going to talk a lot more about the surgery options. I'm a radiation oncologist, so I have a lot of different types of radiation that I use to deal with prostate cancer. One is kind of what we refer to as more traditional external beam radiation therapy. That's the type of therapy where someone comes in to our department on a daily basis and they get a very small dose of radiation, but it's given each day over the course of several weeks. The idea being that people can tolerate a very powerful amount of radiation if it's done very carefully and very gradually.
How many treatments would that include then?
For
typically?
prostate cancer, that can be anywhere from 7 to 8 weeks of daily
Every day?
treatment. Every day.
So 35 to 40 days.
35 to 40 days, very quick. I mean, the treatments are about 10 minutes each, so people just come and go as they go about their daily business. But I tell people it's like having a part-time job for 2 months while you go through it, because this is your daily routine. You have to come in and do your thing.
Is it painful?
The treatment itself is totally painless. It is just like getting an X-ray at the dentist office. The difference is that our machine is much more powerful than a traditional X-ray, but it can also be focused much more carefully. So the main side effects depend upon where we're treating. So when we're treating somebody with prostate cancer, the prostate can get very irritated. The things that Keith was referring to, there can be a lot of urinary irritation, urinary side effects. There's a chance that people can have long-term effects afterwards. They can have more trouble going to the bathroom. They can have trouble with erectile dysfunction, having sexual problems after the treatment. And that's the important basis here, is that we want to pick out the people who don't need treatment, because all of the treatments that we give, whether it's radiation or surgery, they all cause side effects. It's just a question of how much and for how long.
So one treatment is this external beam radiation, and then there's another one with the seeds that we know about.
Yeah, there's a very different way we have of giving radiation where we can actually implant radioactive seeds inside of the prostate.
Now what is a seed?
Well, we refer to it as a seed because it looks just like an apple seed, but in effect, it's actually a very small metallic object that has a very tiny radioactive source inside of it. And these are so small, you can put them inside of a needle and you can actually inject them directly into the prostate. The idea is you basically fill the prostate with these seeds, and the patient then goes home, and the seeds give off radiation very, very slowly over the course of the next several months.
So are they radioactive at that point?
They are radioactive, yeah. This actually makes you radioactive for a couple of months after the procedure is done.
So are there precautions that you have to take? Can you be around?
It's a very tiny amount of radiation. So it's enough that it's not going to hurt anyone around you, any family members or pets or anything like that. And we have a lot of precautions we use to make sure that people are at safe thresholds before they leave the hospital. But we warn people that if you're going to be traveling, you will set off radiation detectors.
Now, is that forever?
No, that's only for a couple of months. The
Okay.
seeds get a little weaker and weaker until eventually the radiation disappears. But the seeds are permanent. They're always there.
Okay.
It's a procedure. I mean, it can be done in the office, but for comfort, we do it in the operating room, and Dr. Bleiler and I do it together. So it's an outpatient procedure where patients come in, they have the seeds put in place, and they go home the same day. So instead of coming in every day to get radiation for 8 weeks, you're getting radiation 24 hours a day, 7 days a week while you go about your business.
And how effective is it?
Well, it really depends on the stage of the tumor. Again, this is where it's so important to know exactly what you're dealing with, because some of these treatments are more appropriate for some people than others. To do a seed implant, you have to be dealing with a very early stage tumor. It has to be one that was caught very early, that there's really no chance the tumor has spread anywhere else in the body. And there are limitations. Some people are not a good candidate for seeds if they have a very large prostate or if they have a lot of urinary symptoms to begin with. Those are the people that sometimes might run into more problems after a seed implant. But we're pretty good at picking out who's a good candidate and who isn't. So that's why part of the assessment when people are diagnosed is we usually have them meet with a team of doctors to talk about these different alternatives. And one of the alternatives is also surgery. I think that's what makes prostate cancer unique, is that most times if you're diagnosed with cancer, you come in to see the doctor, whether it's Dr. Hopewood or myself or whomever, and we say, okay, this is what you got, this is what we need to do, we're going to start next week, let's get going. Prostate is sort of the opposite of that. Prostate cancer is sometimes caught so early that one of the things we talk to you about is, well, let's just watch this and see what it does. And we don't really do that for any other type of cancer.
Right.
And when we decide maybe you do need treatment, there's a lot of good ways to do it. For the most part, they have very equivalent outcomes in terms of how effective they are, but they're very different ways of doing the same thing. The side effects are very different, how much time is involved, and that's why it's important to meet with a group and even get opinions and second opinions with this
Now,
type of disease.
Dan brought something up which I think the community needs to know, that we have a conference every Friday morning where we discuss these cases. And the conference we'll have one tomorrow at 7:30. So there'll be a patient that's been diagnosed with prostate cancer. At the conference, we'll have the pathologist show the slides. We'll have Dan or Keith present the case. We'll have Mike looking at the x-rays of the patient, and then we'll discuss the treatment plan or what we think may be best for this type of prostate cancer. We talk about the risk, the pros, the cons, the benefits, and we come together with our consensus opinion. And then the patient meets with Keith and Dan and their associates to figure out exactly what to be done, and we give them those options. And we do this in a collaborative or all together. And that's something that's done behind the scenes, but it's happening all the time for all of these diagnoses. So rest assured that you're not just hearing from one person, you're hearing from a team, and a lot of times they'll tell you the consensus opinion from multiple different specialists that go to that meeting.
So Keith, let me ask you then. Let's say the consensus is that the patient should have surgery. What are the surgical options for people? They have now robots that are doing surgery. Is that correct?
Yeah. Well, you're right, and there has been a significant technological advance in the management of prostate cancer over the past 5 to 7 years. In the old days, it was perfectly acceptable to remove the prostate through an incision in the lower abdomen. So patients on the operating room table, and you get out the scalpel blade and work with your hands and remove the prostate gland that way. What's changed is the trend towards laparoscopic surgery, and really robotic surgery is just a remotely operated laparoscopic. It's sort of a more precise way to do laparoscopic surgery through a series of very small 5-millimeter incisions as opposed to one large incision. There's not a tremendous difference between the two of those operations, except in the right hands, the laparoscopic or the robotic surgery could get you out of the hospital maybe with less pain medication, get out of the hospital with with a lot less or shorter recovery time. Even though internally everything's recovering the same, the patient sees less of an incision, and cosmetically they like it a lot better. So there's not a whole lot of difference between the two ways to do it. The robotic surgery is sort of the more preferred way, I'd say, nowadays. And in the right hands, it's just as effective as the old traditional open surgery, if not more precise. Everything is magnified.
How about complications? Are there?
So that's just it. What we want to avoid is subjecting men to complications from any kind of treatment for prostate cancer. We want their quality of life to be excellent, especially in cases where we're not quite sure whether or not they're going to develop problems from this cancer in the first place. You brought up a good point. You know, it's not like when Peter sees a bad appendix in the emergency room, there's one treatment for that. When we see patients in the office with prostate cancer, there's literally 3 or 4 equally effective treatments. So we try to make a decision based upon what the patient's wants and desires are. And if they go on to choose surgery, then we talk to them about the side effects of surgery, which include some form of sexual dysfunction, usually in the terms of erectile dysfunction. Men usually develop some degree of erectile dysfunction. Even when things are absolutely perfect to start out with, they'll have a little bit of difficulty in the postoperative period. Nowadays, it's usually not that bad of a consequence. The other consequence that everybody's really worried about is losing control of their bladder over the long term and being, dependent upon others for help with that, or, wearing undergarments to, pad them from leaking. That's been significantly reduced by advances in surgery over the past 15 to 20 years, and certainly with robotic surgery in the past 5 to 7 years, that's less of a concern. So those are the main things. Surgery is always a little bit of a crapshoot in terms of side effects, but for the most part nowadays, surgery is extremely safe, and those 2 complications that everybody worries about, erectile dysfunction and loss of bladder control, are a lot less of a concern nowadays.
Is everybody a candidate for robotic surgery who is a candidate for traditional surgery, or do you have some type of process you go through where you screen patients for one or the other?
I think most of the people who were candidates for the open surgical procedure are also candidates for the robotic procedure.
Well, there's some patients that shouldn't have surgery because they've had other procedures in the past or have had previous radiation for something else.
Right.
And then that would exclude them from the surgery part. Are there any patients that shouldn't get radiation?
Well, radiation can sometimes almost be the default treatment, because almost anybody can do external beam radiation. You just have to be able to lay on a table and come in every day. Not everybody can do the seed implant because, again, there's some fairly strict criteria, and only about 1/3 of the guys I see are even candidates for seed implantation. And there's some very rare conditions where people shouldn't have radiation, but that, we can pick people up pretty quickly.
Yeah.
And let them know
So
about that.
some of the general contraindications of surgery, if you have very bad heart, you've had heart disease, bad kidneys, emphysema, certain same reasons I wouldn't want to do a hernia repair on somebody who's really in poor health. We do have the backup of radiation for those people, where if they can't tolerate surgery because of poor health.
So, Dan, and Pete, everybody here, let me ask you guys, what's new with on the horizon? I mean, we kind of have a condition where I have to say I'm a little disappointed in that we don't have a perfect screening test. We have a treatment that really is effective, but it does cause side effects in not a huge number of patients, but a significant number of patients. And we'd ideally like a perfect screening test and a perfect treatment. Are we moving in that direction, and are there things on the horizon that are going to get us there?
Well, I want to just say one thing about prostate cancer, and you saw it on the slide. 1 in 6 men will get prostate cancer. So if you have 100 men in your high school class that graduate, in their lifetime, 16 are going to be diagnosed with prostate cancer. Now, women, of 100 women in your class that graduate and live to be 90 or 80, 12 are going to get breast cancer. So we have all of this advocacy for women with breast cancer, but where's the outrage among the men? The first thing I would like to say is that the men need to get on the bandwagon and start pushing for more prostate cancer research, because we really need these answers. And right now it's being left to the pharmaceutical companies, where the reality is we should be pushing the government and our elected officials to really push this envelope, so the National Cancer Institute, National Institutes of Health, CDC, places like that can tell us with research what the right answers are. And until we start as a groundswell, men don't ask for directions. Well, we need help, because more men die of prostate cancer than women die of breast cancer. And that has been lost until, if you look at that slide earlier, and maybe they'll show it at the end during the credits, you'll see exactly that's going on. So I would push for advocacy among men's groups to really get more research for prostate cancer.
Yeah, I think you bring up an excellent point, Peter. You know, you've got this statistic where men are dying from prostate cancer. It seems like the incidence really has declined since we started doing PSA testing, and then you have this government body, the National Preventative Diseases Task Force, say, you know, we shouldn't be doing the test at all. The test gets a D- in our book.
Yeah.
So we're kind of going backwards, you know, and when we should be pushing the issue.
Yeah, I think as doctors, we all agree that we would rather everybody get screened and get that information. Where I think the future is going is we're going to get better and better at picking out those guys who really need treatment.
Yeah.
Where the future is going is, and we already have this for breast cancer because Peter and I use it on a daily basis, they can look at the test and do genetic testing on it and tell us, is this a high-risk person, is this a low-risk person? We're going to have those same tests for prostate cancer in the next 5 to 10 years, so we'd rather everybody who has it, we find out, and then let us put you into the right category and help you make that decision on whether you need treatment. And our treatments are just getting better. The technology I have available, the technology Keith has available, didn't exist 10 or 15 years ago. So the treatments will get better, but picking out those guys who really need it is really the hardest thing ahead that we have to deal with prostate
And the
cancer.
data we have now, we're living a little bit in the past, because when the PSA first started, everybody got treated because they couldn't sort them out. So now we have to reverse that trend and really just pick the ones that are going to benefit from the treatment. I think that's one of the bottom lines of this presentation tonight.
Well, I hope the audience enjoyed it. Actually, I learned quite a bit tonight, and I hope you did also. I do want to point out that there are a couple of sources that I think you might want to use, sources that actually I found helpful. One is Up to Date has a very current resource, and you can find it by Googling prostate cancer screening up to date. And it's the March 2014 edition of that. Also, the American Cancer Society Guidelines for the Early Detection of Prostate Cancer was updated in 2010, and that has a PDF file that is actually quite good as well. So I guess I want to thank my partners and associates here. I think you guys did a great job, and I hope that it looks like the future is going to be better for those who were diagnosed with prostate cancer.